We're now going to have a conversation about how a human-centered systems change approach can holistically address the root causes rather than solely the symptoms of societal issues. In other words, how to put people, human beings, at the center of the process to address complex societal problems. This conversation is going to look at this approach through the lens of the community health worker model. Moderating this discussion will be Raj Kumar, president and editor-in-chief of Devex, which is an independent news organization that he co-founded as a graduate student at the Harvard Kennedy School. Kumar is also the author of The Business of Changing the World. It's a book about the future of global aid and philanthropy. Raj will be introducing his panelists, so please welcome to the stage Raj Kumar.
Good morning. Wonderful to be with all of you. This has become an annual tradition for me. It always leads to some interesting conversations this time of year when people in our community, in the global development and humanitarian community, they ask me, where are you traveling next? And I say, Beverly Hills. And where are you going to go? I'm going to go to the Beverly Hilton. And people associate this venue rightly with celebrities. There's lots of award shows that happen here. But for our community, this is our celebrity show. And we get to meet people like the people I'm about to introduce to you who are, in our world, they're changing things. They deserve to be celebrated. And that's one reason for me this event has become such a special and inspirational moment. You heard from Father Boyle just now, that it can really reframe the way we think about issues. And that's what we aim to do today. Because if I tell you that in the world, more than half of people don't have access to basic medical care, if I tell you that there's a massive inequality in terms of your outcomes in life based on where you live and where you're born, you might think, well, there's not so much we can do about that. We just need a lot more money, or maybe there's a new technology that we need to consider. But actually, there's a really ancient technology that we're going to talk to you about today. How many people in the room have heard of a community health worker? So maybe a third or a half. It's not a new idea, but it's something that has got the potential in it to really change the world. And I want to start with one of our panelists on stage, Margaret Odera, who is a community health worker. You've come all the way from Kenya, in the Matari district in Nairobi. Maybe we can just start with what is a community health worker?
Okay, a community health worker is a member of a community that is trusted by the community and acts as a bridge between the community and the healthcare workers. One advantage of a community health worker is because the community health worker understands the language of the community, whether it is a health language, cultural language, or a religious language, and they can relay messages very well in a way that these community members will understand. So we do mobilizations, sensitizations, referrals, linkages, and follow-ups. We are not a replacement of doctors and nurses, but we complement their work in the community to make the community members understand the benefits of going to the hospital and to understand in their own language so that they get to know the benefits in their own language without putting the complicated languages of doctors that they don't understand, and to make sure that these community members accept issues like vaccination, because without changing a mindset of a community, you will not be able to even cure that community. And there is no global health security or universal health coverage if we don't have the community health workers. Most of the time, discussions are happening at high level with the high level peoples like doctors and nurses, but the real outbreaks and the real pandemics happen in the community. So it's very important to involve community health workers in events like this, and I'm so much honored to be here. Thank you.
Margaret, just briefly, you live in the same community where you work, right?
Yes.
And how many families do you serve?
I manage 100 houses. Each community health worker in Mathare, I live in a slum. that is called Mathare North Slum, and I report to Mathare North Health Center. So I manage 100 households, and we are 200 community health workers within that Mathare slum, and each and every community health worker manage 100 households with a total of around 200,000 community members. Yes.
Just to give you a sense of the scale, right? That you have to know what's happening in the lives of 100 people, 100 neighbors.
Yes.
And who is pregnant, who has an ailment, and to be able to make that connection. Maybe, Marc, I can bring you into the discussion. Marc Julmisse is the Chief of Clinical Systems Support at Partners in Health. You've spent a lot of your career in Haiti. You work globally as well with Partners in Health. You're a nurse.
Yeah.
One of the things Margaret mentioned is this connection between the community and the traditional formal medical system. I talked about this being an ancient technology. Of course, there's a long history of people in villages having a local healer or someone you turn to that you trust who lives in the community. Why is it important to have that connection between the formal and the village level? You've seen this play out in real life as a nurse. Like, what is it like? Explain it to people.
I think I'm just so proud to be sitting next to, because this is what it should be, where you're having a clinician, a doctor, a nurse, a community health worker. That is your healthcare team. And I think, and I'm privileged to have worked where we work in Haiti with Partners in Health, because that is a model. It's talking about partnership, community level partnership. When you're talking about accomplishing or addressing maternal or infant mortality or any of the host of problems that we address, it's together. Those, and I believe it was said earlier, those that are closest to the bedside, closest to the patients, are those that have most information. Mm-hmm. We're coming from one area, but then you have a different lens that helps me interpret how I'm supposed to be providing care. And because of the partnership with our community health workers and this bi-directional partnership, sharing it, it helps me as a clinician change the way I practice. Mm-hmm. Because if they're saying that's not going to work, and I'm thinking, no, this is the traditional way that we have to do it, but you're saying this is not going to work the way you're trying it, this helps us actually make the impact that we want to make, but not just write something down that sounds good.
Well, and so often I think it's easy if you come at this for just a brief moment as a doctor or a nurse and you don't know the family, to think, well, here's a treatment, here's a medication you can take. But actually, maybe the family doesn't have access to clean water, or maybe they don't have the right nutrition, right? And you have to see them as whole people to actually address whatever the underlying problem is.
Completely. You're almost getting me to talk to one of my favorite subjects of child health, which I promise I could go off on a tangent on it. But one of the big parts that we've seen with one of the integrated maternal child health projects that we did, it's directly working with community health workers. It's one of our goals from the beginning was, how do we strengthen the link, truly strengthen the link between community and clinic? And in that is when we go into the communities with the community health worker working together. So we actually asked all clinicians that are part of this program to go together with the community health workers so that we're also learning in there and we're walking a mile in our patients' shoes. By walking a mile and understanding and having your interpreter to help you understand, when we get back, we actually look at how are we prescribing, because it's not about the physical ailment or whatever it is. Pregnancy is not an ailment, so I'll put that out. But it's specifically in some of our pregnant moms, because we're able to go with our community health workers, we're able to see the distance it takes for them to get to the facility. The community health worker will be the advocate and say, no, we need to get a little bit more materials within that, because it's going to take too long to get that. Because of the community health worker, I can tell you in one community in Haiti where we had to go pretty far up into the mountains to get that, they were able to tell us the delay to receive care is also because they have to take off the door in order to put a pregnant woman on and bring her down the mountain to get to an area that we can send the ambulance.
So the door
to
is
get
a
her.
stretcher.
Right, but then because working together, they were like, but here's the danger. They can fall off if you don't have it, because it's not like a smooth path. So we got the language, blancas, the portable portable stretchers, thank you, with that. But it's also because it's not just, again, let me come give you care and do the evaluation. It's what are those risk factors? What are those impediments? What are those barriers that are going to stop you from getting the full, complete care that we need to provide for you.
Yeah, it starts with actually meeting people where they are, asking them what they need. I think it's fantastic that we have a panel that represents exactly the health system many people want to see, right? As you said, a community health worker, a nurse, and a doctor. Madeleine Ballard, you are the CEO of the Community Health Impact Coalition. You've spent a lot of your career on this issue. You identified this pretty early. You were working with Last Mile Health. You helped to really promote the issue in Liberia, and Liberia ended up with a national program of community health workers, which was a key in the Ebola response in 2014. We've been talking about this for well over a decade. Community health workers have been around 60 years in many countries. There are several million around the world, and yet many are not paid. They literally don't get a salary. They work in their community on a voluntary basis, and then maybe there's a project that comes, right? A malaria project that comes, designed in a conference room, maybe in London or something, and they get some fee to go around and do malaria diagnostics work. But they're not necessarily integrated into the whole system. You're working to change that. What has been the impediment? Like, what is the thing people are missing about the opportunity here with community health workers?
Yeah, I think we can all agree that it's fundamentally unjust to expect the poor to volunteer as a condition of achieving their own right to health. And when we talk about what's required to change things, I mean, the title of this panel is System Change. A lot of folks are like, well, you know, I understand treating patients, but what does systems change mean? And I think when we talk about systems change, we're talking about transforming the conditions that hold a problem in place. And so, as you said, in our work at Community Health Impact Coalition, I work together with Margaret, you know, we're tackling why is it that millions of community health workers are unsalaried, are unsupplied, despite compelling evidence, and I say this as an epidemiologist, compelling evidence that community health workers save lives, increase equity, and create a pretty profound return on investment. So the conditions that hold the problem in place are threefold. Up to very recently, there was no international guidelines for ministries of health in terms of how to roll out these programs. Insufficient funding in order to make, you know, the startup costs of that transition towards a national community health worker program. And then just national policies that didn't set CHWs up for success. And it's only by looking at this problem through a systems lens that we can identify those bottlenecks that are creating a problem or poor conditions in your system of interest. It's guidelines, funding, and policy that need to change to set CHWs up for success.
I might add a fourth to that list, having listened to Father Boyle just now, who said that to change systems, you have to change people. And I do think there is a sense that we can decide at the top how to fix a health system, and that you can invest in that formal system, and that community health workers, they're a nice thing, but maybe they're not as core to the system as it should be. You're smiling. You were part of the WHO group that tried to set these guidelines at a global level. Am I right that there is a mindset shift needed in the global health community to put CHWs in the right place?
Margaret, what do we say? Nothing about us without us?
Yes, nothing about community health workers without community health workers. Because as long as the health care fraternity will have a negative mindset about the community health workers, that they are not up to the standard, there will still be outbreaks that will go out of control, the way we saw with COVID. HIV prevention in Kenya has been successful because of community health workers and mentor mothers like me, mentoring HIV positive pregnant and lactating mothers to make sure that they have a HIV-free child. And I think with those impacts that we are creating in the community, making sure that our children, setting as example, because I am a mother of 3 HIV-negative sons, and I am HIV positive. So the community, the mothers who are HIV positive in Mathare, in my community, needs somebody to mentor them and to tell them this is the way to go so that your children will never be HIV positive. And this has worked very well in Kenya right now, the positivity rate of mother-to-child transmission of HIV is below 2%, from 82% in 2000 and below 1%. It is because of the efforts of the community health workers. It is because a community health worker followed me when I was down, I was dying around 20 years ago, and this community health worker followed me. I avoided the services of a community health worker because it was a death sentence during that time. And she never gave up on me. She followed me up. I shifted from one house to another. She followed me from one house. She made sure that she finds out where I was hiding and convinced me that ARVs really worked because I was prayed for and I was not healed. So when the pastor chased me out of the church and told me, see you at the mortuary, I knew I disconnected myself from the world. And because community health worker saves life, a community health worker saved my life, and that is a mindset that she changed. She changed my mindset. And if this mindset is going to be transferred to the health fraternity to see how community health workers saves lives, because it's not me alone, other mothers who have their HIV-negative babies, that is an impact that a doctor can create by working, and a nurse can create by working hand in hand with a community health worker who understands the language and creates that rapport between mothers, between fathers, between children, and between all the traditional, the cultural languages that we identify with. And I think nothing about us without us, and that mindset should be changed even in the higher level of the health fraternity. Yeah.
That's right. And I think HIV is such a good example where you need to address stigma, and who's better to do that? Not necessarily someone sitting in a hospital in a city, but people in your community. Yes. And then you need to have adherence to take medication regularly. It's not a one-time thing. So someone who has to be part of that community who's following up with you, making sure. It makes a big difference. I had a chance, you're with Partners in Health, and I had a chance to visit your University of Global Health Equity in rural Rwanda a few years ago. And that's a remarkable place. And I remember talking to one of the directors there, and they said, we see the community health workers as part of our faculty. They're in the same way they have doctors and nurses. It's that mindset shift that's required. Partners in Health is famous for a systems approach to health. And I guess that's why you're on this issue of community health workers. Yeah. To this broader theme of what do you think is missing or needed to get community health workers in the place where they need to be to have this kind of systemic change we want to see?
I think we mentioned it a little bit, and I think we just have to underline it. It's inclusion. It's understanding that they are part of the healthcare system and not an afterthought. I think a lot of times we're like, oh, go ahead and get the community health worker, but not really have them part of the planning of it. Because we have this great planning, and then we do a training for the community health worker without them, and then say go. And then sometimes the community health worker is saying this is not going to work. I do remember even with COVID, when we were talking about vaccination, there was great planning that was going on in different organizations, and you would hear people from the community health workers saying this is not going to work. Yeah. And if we are really going to be intentional about changing healthcare systems, then we need to include all participants or that are part of the healthcare team, including community health workers. Because you have a degree, because you have a certificate, does not only mean that you should be at the table. Those that have, I have to keep going back, those that are closest to the patients, closest to the community, are those that have the most information and really can help make changes, not for the moment, not for a program, not for a clap on the back, but actually make long-term systemic changes, changing mindsets, as Margaret did share. So yeah, who needs to be at the table is community health workers.
And I build on that, Mark, because I think one of the biggest ways that we are able to do that, we all work together through Community Health Impact Coalition. I think coalitions are that engine of systems change, because it's only by working together that we can actually wield influence on a scale necessary to change these norms, right? To create those multi-country insights, to create that surround sound effect that we're kind of just creating on this panel right now that makes the message impossible to ignore. And I think one of the most powerful things about working together in coalition in its highest form is it connects the proximate to the powerful, and it makes them the same. Margaret is sitting in a room with the Minister of Health of Kenya and redesigning the health system. Kenya has just committed to professionalize community health workers. So, yeah. I think, the bottom line is together, there's a lot of infighting sometimes within the health field. It's very hierarchical, but ultimately together, our voices are stronger, our resources go further. We can do more for patients than any one organization or person on its own.
Madeleine, maybe you can give us just a little insight into something we've already mentioned a couple of times. I've talked about the vertical nature of some of the funding and malaria as an example. Marc just referred to this as well, like it's not just about one program. We need a systemic approach, professional, national community health worker program. What is it like today for community health workers with these vertical what does it actually mean in plain terms?
Yeah, I think Margaret could add on to this, but you might go to, I used to live in rural Liberia, and you might go to a town of, let's say 15 households in a rural Liberian jungle. You've traveled, 15 hours in a car from the capital. You've then gotten on a motorcycle through the jungle. You've rode, in a canoe, and now you're there, and there's 3 different people with 3 different phones, and they're all working for different programs. And all of us have been patients, right? And when we are in that place of being sick, in that place of needing care, you're not thinking, I need to go to one person for my ibuprofen and someone else for, to get my malaria drugs. Like, you just want to go and get one-stop shop, right? And so I think integration, it's both the right thing to do and the smart thing to do, and that's changing. I think we have a lot of financial instruments that fund individual programs, and they've saved a lot of lives. We have to recognize that. And I think we also know that what's gotten us here is not going to get us to the vision that Margaret expressed earlier, which is universal health care for every person in every village.
I think it's highly related to what Peter talked about this morning about localization, right? Getting closer to the issue and getting people who have lived experience to be in the lead. When you start there, you end up with an integrated approach. When you start thousands of miles away, you end up with these vertical programs where you're asking Margaret to go door to door and ask a series of questions about one disease, and then the next day a series of questions about another disease, instead of just asking the person, how do you feel? I see you nodding. Does this relate to you, Marc?
I love when we're talking about integration or looking at an integrated healthcare system. Specifically, we have in Haiti, we have polyvalent or community health workers that are trained in multiple areas, so that if you're going to the community, and they're community health workers, but also accompagnateurs. We accompany you throughout the full journey of what you need, so it's not just siloed off, but it's a true accompaniment. And one of the things I do love about the integrated is sorry if I have to keep going on maternal child health, that is my thing, so I will keep doing on that one. But just using that for an example is a mother that's pregnant has a host of other issues. So if we're going to only have a community health worker that's focused on maternal, but then she also might have HIV, but then she almost might have an NCD or a non-communicable disease like hypertension and diabetes and so forth, and then she might also have mental health issues. Do I need a community health worker that is trained separately for all this? Or how do we integrate and put that care together? And how many times will this parent, this mother, have to come to the health facility to receive care or follow-up? And so how do we make it easy? Because when we incorporate, going back, when it's a complete team, you decrease cost for that patient. And you decrease the issues that they have the distance and travel. You decrease some of the more barriers and obstacles of care that they have to receive. And you decrease so many people coming at them from it's overwhelming to the point that you might just not connect with your patient anymore.
And I don't want people in the room to get the sense that this is only relevant in the lowest income settings. Talk to us, Marc, about the United States and community health workers here.
I'm newly returning back to the United States after living in Haiti for like 15 years. This is actually something that we are really supporting Partners in Health is how do we get community health workers that are paid within the community, that are working together with this, because we've seen this model have worked in countries that we serve. We have the accompagnators, we have community health workers. Like in Haiti, we have about 6,000 staff members. 2,500 are paid community health workers out of that 6,000 staff members. This is something that we have to bring in the U.S. and we have to advocate just as hard as we're advocating for other countries, that we have to advocate in the U.S. because that connection, and I know many of us, I know I've gone into the system now, but having somebody walk alongside of me and understand what's happening and be able to be my advocate also with the health system, it's part of a team. And I'm really proud that our team in the U.S. is now really advocating for the integration of community health workers and paid community health.
I mean, if you think about the U.S., we have a lot of the same issues, whether it's misinformation about medical care or adherence to taking your medicines, or questions about vaccination, or maybe it's nutrition. These things are all very relevant everywhere in the world. And it's not just something for the lowest resource settings, but it's an ancient technology in a way that applies now. There's also a modern technology angle here, which is that now there's the ability to give a community health worker a smartphone. Many have them.
Yes.
And what can you do with that? I mean, talk to us about the opportunity now to better empower community health workers with technology.
Okay, yes, I really appreciate the government of Kenya for starting electronic health information system, ICHIS. And we were taken through a training and given mobile phones that happened in September last year. And then in October, the president formally launched the community health workers and gave us the name community health promoters from volunteers, so that we may be recognized by the laws of Kenya, and that was very important. Now, electronic health information system is a way of transmitting data and reports from a household directly to the Ministry of Health. So when I go to a household with a phone, there are every kind of disease, every kind of information is inside that phone. There are many columns, like 10 columns. The first column is maternal child, the other one for diabetes, the high blood pressure. And with the smartphone, we are also supplied with a high blood pressure machine. We have the machine to test the blood sugar right in the household. And this happened last year, so for 35 years, we were just having a pen and a paper. And this kind of transmitting data directly and immediately has one advantage that it has. It saves lives, because if we find somebody with a hypertensive situation in the community, it is very easy for the Ministry of Health to know that there is something going on the ground at that very moment, other than waiting for me to go and submit a report. So it has given us easier access to transmit data. And then also another advantage of this electronic health information system is to store the storage of data and information of every patient. Each and every patient has got its own file inside that app. So it's easier to access data from each and every patient at any time. So yeah.
And these are, I'm thinking where PIH works. A lot of these are countries where there are far too few doctors, far too few nurses. There's an opportunity, though, with community health workers, because training can be much quicker than for a doctor, for example. So talk to us about some of those places where you work, and what is this opportunity to bridge the gap, given this workforce challenge?
With technology, or?
With both, really, right? Because now you can empower that community health worker. I mean, there's even like ultrasound devices that are coming out. You've probably seen or used some of these.
Absolutely. I think I love with the data and so forth. We have an EMR system, and one of the things when we send our team out with a tablet, they're able not only to capture information and have it integrated, so we have integrated with it back into our EMR system, so we're able to do continuous care instead of having interruption in care, waiting for data to come in a paper form. Some things are lost and so forth. The other part is if there's other issues, because we also add household surveys and in questions about what's going on, the distance for water supplies, we're able to link to other resources. So you're able to either geolocate, you're able to see where are those clusters of information. So it's not just we're going to capture the data, it's also analyzing the data. What are we seeing? What's happening in this community right now? Where do we need to get more people out there? And with our community health workers they'll say, we have an issue right here. Now they have the data to back up that issue that's going there.
So maybe the issue, for example, is they need a water point closer to the village because women are walking far too far, there's insecurity when they go that far, et cetera.
Or you're seeing one of the communities that we serve, what we started seeing and working together with emergency services, we're seeing so much more patients were coming with waterborne disease. When we were able to look at where we were documenting information when we were doing our community, when our home visits and getting information, we were able to overlay that and say, you know what, this is a community that we actually need to do a WASH intervention here because it's also affecting patient health. And so there's so many other factors in there. It's not just saying we're going to give a nice little shiny tool. That shiny tool actually makes differences. And in the hands of the right people that can get to the location to where the patients need, then you could actually get more real-time data of where do we need to put our interventions.
Alan, what do you think? What is the big opportunity today, given the technology revolution, at the same time that you and your coalition are out there trying to create professional national programs for CHWs?
I think every good systems change initiative needs more than a mission statement, right? It needs a scoreboard. And that's what technology can help us do too. We always say, as a coalition, we are a team, not a club. What does that mean? Well, clubs have a shared interest, teams have a shared mission. Clubs are socializing, teams are there to win, which means you need to know the score. And so together, we've worked actually on a global dashboard, the first of its kind, the largest of its kind, that actually shows you up-to-the-minute information from more than 100 countries, what countries have policies that salary and recognize community health workers like Margaret. And every time a country, like Kenya just did, adopts one of those policies, it turns purple on the map. And our goal is to turn the whole world purple. And and we're going to get there. We're at 40 countries who've done this at this point, which deserves a round of applause.
It does.
And there are maybe 60 more to go, so we got our work cut out for us. But that's actually incredible progress. And together, I think what we've learned in the past couple of years with COVID and other things is that the power of pre-existing partnerships, they pack a punch, right? When we're already working together, we can bring folks together, we can coordinate a response, we can mobilize resources in a way that's unrivaled. And so if we can just continue the work, continue the solidarity, then I think we're gonna reach a new reality, and we're already creating it.
Well, in the news business, it can be hard to find a good news story these days, and I hope we've brought you a real one today on stage. Thank you so much, all of you. Please join me in thanking this panel. Thank you.